good evening, everyone. Welcome to another ESID Grand Rounds session. My name is Boris Karanovic, and I'm a clinical immunologist working with adult patients in Zagreb, Croatia. I am also currently the chair of CVID Care and Development Working Party, and it is my great honor to be your host for this evening alongside my co-host, Klaus Wadnitz. Hi, Klaus.
Hi, Boris.
First of all, I'd like to thank Siobhan Burns, the chair of Clinical Working Party, for her kind invitation and for this wonderful opportunity to be here today with you. We have an exciting topic for today. It is the gastrointestinal complications in CVID. I'm delighted to welcome our speakers, who are all eminent experts in this topic. And the plan for today is that we will first hear these four interesting talks of our speakers, and later we will have a discussion and answer some questions. So during the talks, I would like the audience, to write your questions in the Q&A section. It might be helpful if you would actually address the question to a specific speaker. It would just maybe make the discussion easier later. Of course, if you miss any of today's sessions, the recording will be of course available on YouTube alongside the other Grand Round sessions. So I think this is enough information, introductory information. I don't know, Klaus, if you want to add something.
No, thank you very much, Boris. This was excellent. I think the only thing to mention is please be interactive. As Boris mentioned, this will happen at the end through the chat, and I think Eleanor already gave some information about that as well. So yeah, please ask. This is a great chance to discuss.
Okay, thank you, Klaus. So if you agree, I would like to first present a short introductory case about patient, difficult to treat CVID patient with enteropathy. It's about a male patient born in 1986. He was having recurrent respiratory tract infections during his childhood until 1995, when he underwent tonsillectomy, after which he still had some recurrent respiratory tract infections, but they were a bit less frequent. He was first hospitalized in 2007 at the age of 21 because of a severe pneumonia. Then again in 2009 because of sinusitis. Then again in 2010 because of a second episode of a severe pneumonia, and hypogammaglobulinemia was established at that time. But he only received basically just a one-time dosage of IVIG. He first saw a clinical immunologist or rheumatologist, because in Croatia and anyway in this region, those specialties are actually intertwined. So we see both rheumatologic and immunologic patients. He was seen by an immunologist in 2012 at the age of 26, and a diagnosis of CVID was established. He started receiving regular monthly IVIGs, but he said he had some transfusion or allergic reactions to it, but he had no significant infections. In 2016, subcutaneous immunoglobulins were available in Croatia, so he was transferred to that type of therapy, and he was basically fine with just occasional sinusitis. His first real problems start in September of 2019 at the age of 33, when he had diarrhea and abdominal pain. His sinusitis were more frequent and required antibiotic therapy. During a period of 6 months, he had twice C. diff colitis and was treated, of course, with antibiotic therapy, but also his subcutaneous immunoglobulins, their dosage was elevated, or rather their frequency, that he received them twice weekly. In a period of 6 months, so until March of 2020, he lost about 20 kilos, and then he was hospitalized because of diarrhea and sinusitis, and diagnostic workup showed lymphadenopathy and GL-ILD. The colonoscopy showed nodular mucosa of sigmoid colon, and those were supposed to be some residual changes from C. diff colitis. The biopsy showed unspecific colitis, and you can see here that his total protein values, albumin, and also gamma globulins were all low. So he had hypoproteinemia in general. He was started on facilitated subcutaneous immunoglobulin in an elevated dosage and also an elevated frequency, and also on mesalazine. Unfortunately, at that time, COVID-19 pandemic hit Croatia as well as two devastating earthquakes. So during all this chaos, the patient was lost from follow-up from his clinical immunologist, but he remained in contact through email with a gastroenterologist. So in what we later found out that he had another episode of Clostridium colitis that was treated, of course, with antibiotics, but his gastroenterologist then decided to discontinue mesalazine. In February 2021, he underwent another colonoscopy that showed nodular hyperplasia of terminal ileum. And during this time, he had frequent diarrhea that maybe he would have some short-lived improvement on antibiotic therapy, but still it was really bothersome. And he was started again on mesalazine, but at this time he basically just gave up and he stopped himself facilitated subcutaneous immunoglobulin therapy. And he was lost from follow-up during 2 years. He didn't see his gastroenterologist or an immunologist until he showed up in our emergency room at our center with malaise, severe diarrhea, about 25 stools a day. And you can see here that he had a significant electrolyte disbalance, and he needed to be admitted to intensive care unit. He lost a total of 50 kilograms in this. This is a 4-year period, but still, it's a lot of weight that he lost. In the intensive care unit, he was treated with electrolyte and infusion therapy, parenteral nutrition, and when he was stable, he was transferred to our ward. The diagnostic workup showed lymphadenopathy, pneumonia, GLILD, and bronchiectasis on the lungs, but also small intestine thickening. We performed colonoscopy and enteroscopy, which showed irregular granulated mucosa and inflammation, basically, of the ascending colon. And the biopsy showed nodular lymphocytic hyperplasia and something in accordance with an inflammatory bowel disease. We treated him with, of course, with enteral hyperalimentation, vitamin, iron supplements, antibiotics, but also we started methylprednisolone, and he received IVIG. In a month, he was feeling a bit better. We tapered down prednisone to 20 milligrams. He again started, he continued his facilitated subcutaneous immunoglobulins, and we started azathioprine at this point. And I'm happy to say that on his last consult just a month ago, he was doing fine. He has no diarrhea. He gained some weight. He doesn't have any significant infections. And his current treatment is 10 milligrams of prednisone, facilitated subcutaneous immunoglobulins, and azathioprine. So in conclusion, we have a patient with CVID with recurrent infections, GLILD, but also enteropathy, which in part is certainly due to his altered gut microbiota and all these gastrointestinal infections, but also an autoimmune disorder, which is the topic for today. And he had a good response to glucocorticoids and azathioprine. So, well, thank you. So, I guess after this short introductory case, where basically which is the reason why we're all here, because of our patients and to learn more how to help them, I think that we should move on to our first speaker now. So our first speaker is Klaus Barnatz. He's a professor at University of Freiburg and a senior consultant at the Center for Chronic Immunodeficiency Medical Center, University of Freiburg. He's the group leader of the research group of human B-cell immunodeficiency, and his areas of expertise are immunodeficiency, autoimmunity, and B-cell immunology. So Klaus, if you would be so kind.
Thank you so much for the introduction, Boris, and thank you for presenting this case, which I think we will have a chance to discuss later. So the topic I was given is to highlight one aspect of enteropathy and CVID, and this is something which is close to my heart, which is when we looked at the biopsies of our patients, we discovered a strong interferon response, and the interest was, is this related to viral infection or others, and especially in regard to the several times detected norovirus infections in our patients. These are my disclosures. And this is obviously an ancient knowledge that the gut health is very important, not only to the gastrointestinal symptoms, but in general. And I think we see many links from gastrointestinal dysregulation to immune dysregulation on a systemic basis. And this is one way of looking at it, and Silja will present later. And I very much like this review they wrote, highlighting many aspects of immune dysregulation in CVID. And I just would like to recommend that you have a look, and especially into the also aspects of the gut inflammation playing a role in there, which is already shown here. The hypothesis we had at that time when we started looking into it, that our patients with immunodeficiency, some of them have a genetic predisposition, others have none identified. Many of them have in common a dysregulation of IgA production in general, but especially in the gastrointestinal tract with nearly absent plasma cells of IgA. And associated with this and in communication with this, they do have altered microbiomes. They may have an impaired pathogen control. This affects altered barrier function, inflammation, and a change within the local tissue where pro-inflammatory CD8 T cells, especially in the case of celiac-like disease in our patients, increases, which changes the cytokine milieu, increases inflammation, and contributes to enteropathy. And this enteropathy definitely contributes back to immune dysregulation in our patients. Now, the questions we asked when we started this is this true? Can we visualize this? And can we identify pathogens? And with a special focus, since we had a few patients with norovirus infection, can we see whether this might add to this dysregulation or whether this is just a bystander infection in our patients? Now, a short introduction to norovirus. It belongs to the Calciviridae. As you can see, it was actually not the first time. I think the Danish people claim already much earlier detection of it, but it was in Norwalk. It was discovered in the States in Norwalk, and that's why it received the name norovirus in 1968. It is an ssRNA virus, and there are different genogroups. Two of them are human pathogenic, with the human genogroup 2.4 being one of the major causes of norovirus infection, not only the acute in the general population, but also of the chronic infection in immunodeficient people. This is immune system the adaptive immune system plays a major role in the defense against norovirus. It has been shown in mouse models that B cells and IgA as well as T cells play a role in clearing the virus. So again, arguing why immunodeficiency might be predisposing for chronic infection in these. The transmission is typically person to person. It can be also food related. It's a chronic disease in immunodeficiency. This has been described in HIV. It has been especially early on described in organ transplant, but also in stem cell transplantation and predominantly in our field in CVID patients, but not exclusively CVID patients. It is often associated with secondary complications. It has been described in several case reports that there was a need for parental nutrition and a need for really treating this disease, with several attempts failing while it required additional control of the inflammation in the gut tissue. So what is the relation and what is published in regard to CVID and norovirus? And again, I here apologize to all the people who have published. There is quite a bit of literature, mostly case reports. I think one of the striking and provoking one was the publication from Kumar's group from Cambridge with Woodward et al. And the American Journal of Gastroenterology in 2015, where he described 8 patients with chronic norovirus infection, which were the ones which had villus atrophy. So the paper came across as a norovirus would be the main cause and driver of the severe form of CVID enteropathy. And this was the nice picture, and this is taken from a later publication from the same group, where you can see here the severe inflammation within the mucosa of these patients during norovirus. And he had 2 patients where ribavirin was able to clear these patients, and you could see the recovery of the mucosa in this single patient. Unfortunately, it didn't work reproducibly, and therefore a later study, and this was for one example of a study where cases were brought together by David Lowe and the Oxford group, just looking at 10 patients with CVID with different treatment regimens, which you can see here given, and with green indicating an clear response, while yellow was an intermediate response and red was failure. And you could see the discrepancy that while some actually showed a viral response, they may not necessarily have at the same time shown a clinical response for, in this case, for example, to nitazoxanide, and others had an improvement of symptoms, however, no virus clearance. So there is not a clear relationship between the viral response and the clinical response. However, there are individual patients where it could clearly be shown that clearing norovirus is helpful, improving health and the local symptoms of enteropathy. Sorry, I just go back one more time. Norovirus has been described in many cohorts, and here I just, this was the last publication from the US, from the New York cohort, where it was seen in 7% of the patients associated with enteropathy. And it has been shown that, and this is again Celia's work recently also published in this year, that in enteropathy, independent of norovirus, that they could see what the signature panels would describe as a virus response, which was altered in CVID patients with gastrointestinal issues compared to CVID patients without at least clinically overt symptoms. Now, having said this, this was a study we had set out already for quite a while, where we basically took duodenal biopsies. So we are really focused on the upper gastrointestinal tract, unlike what was just described partly in the patient, where we did whole tissue digestion, extracted RNA, and did tissue RNA-seq. And at the same time, we performed histology and flow cytometry. This is a description of the 13 patients, which then were analyzed by the RNA-seq, and 5 controls. And these were partly norovirus positive. They did or did not have IgA plasma cells or plasma cells in general. And this is the description of the Marsh score, indicating the histological severity of the disease. And all these parameters were included in the study to try to draw conclusions, who is driving what and what is associated with what. We had 72 biopsies in total. 30 were actually Marsh 0. A frustrating finding, which we often have, is that we can see that the patients, despite having diarrhea and symptoms, they do not have any findings according to the Marsh classification. 21 were Marsh 1 to 2, and 21 were Marsh 3, which indicates villus atrophy, which you see here, indicated as the most severe form of enteropathy. Of the patients which were included, 49 were tested for norovirus in their stool, and 9 of the 19, which is 47%, of the VA positive patients were norovirus positive, and only 13% of the not villus atrophic patients were norovirus positive, already hinting that there was some association with a more severe histological phenotype of norovirus infection. And this was also shown here, and a certain association with villus atrophy and the absence of plasma cells, which I will not go further into tonight. What you can see here is sorry, I just need to make this small so I can see all. Basically, the flow cytometric analysis, and in red, you see the norovirus positive. And what you can see that the norovirus positive patients rather have higher T-cell infiltration into the mucosa, while associated with the different histologic grading, you can see some increase of T-cells in general. But again, the norovirus positives and CD8 cells, especially shown here, are very high in these double positives. Interestingly, within the CD4 cells, and this has been previously seen by others, that IL-17 producing cells is rather decreased in these more severe forms and also in the norovirus positive patients, while the majority produces interferon gamma, which was shown here by histology. The brown staining indicates the presence of interferon gamma. Here you see the healthy control where basically there is no interferon gamma staining. This light brown you can see here is just the attachment to the mucosa. This is not interferon gamma staining. Here you can see already some hint of brown staining within the tissue, while you see the very severe interferon gamma production in villus atrophy of this, showing that there is a strong local type 2 interferon expression. And therefore we continued and looked at the cells. And here we worked together with Anja Hauser in Berlin, where we had the chance to use milk, where we could stain up to 20 different markers within the tissue. And again, you can see the increasing number, and these are indicated by the arrowheads of intraepithelial, and these are mostly CD8 cells, where you can see the increase of CD4 cells happened as well, but this is mostly interstitial in these patients. And this is going along with the histology. You can see the increase of granzyme staining. And here you see very nicely, it is in the epithelium of intraepithelial CD8 T cells expressing high granzyme B. So they're not only there, but they are cytotoxic, contributing. So T cell activation and T cell inflammation plays a role in the disease of enteropathy and CVID. It is not, and now these are the first data I'm showing you here. It is not only the T cells, which you also see reflected in the RNA-seq by several pathways which are indicating this, but you do see also innate immune response, and this is something which was striking, is the very close proximity of macrophages and CD8 T cells in these BA lesions, which you can see here, hinting that this is probably a combined effort of innate and adaptive immunity in the destruction of tissues. And already here you can see in the comparison of no VA as well as of VA, so villus atrophy, so patients with not, where it's not as severe the disease, and the patients with more severe disease. In the comparison to healthy controls, they have a very strong induction of interferon gamma, but also of type 1 interferon responses. While, and this has been published previously by Shultsenko et al., the digestive capacity of the tissue has decreased according to the inflammation which is happening there. Now, we were interested in looking more closely at this interferon signature. And the first thing, which you can't see very well because it's too small, but you can see these are the MARSH 0. So the pathologist writes you back, there's nothing to see, we don't see any inflammation, but already these have induction of interferon genes there. So interferon signature is already seen in MARSH 0. The second thing you can see here, and we did this with qPCR analysis by looking at targeted, specific and targeted genes of interferon signatures, that you do see clear representation of type 2 response, like interferon gamma as one of them, and CXCL10, for example, as another one. But you also see clear indicators of a type 1 response in the tissue induced, and some of them are stronger induced in the villus atrophy tissue than in the non-villus atrophic tissue. Does this interferon signature lead to any difference? The answer is yes. We were able to do in the cell milk analysis to do phosphostat-1 staining, and we do see phosphostat-1 staining popping up. Not only here, you can see it in the interstitium in the CD4 cells, where you clearly see an overlap of phosphostatin-1 and CD4, but we also see it in the CD8 cells here, where you can see that both cell populations are induced. The other sign that there is a strong induction of interferon gamma in the tissue is what you see here. You see here, usually the tissue should be dark blue, as you can see here. Here in the non-villus atrophic tissue, you see already some turquoise, and here you see much more turquoise going even into the crypts of the tissue. And what this means that these epithelial cells express MHC2. So they become immune, prone for immune response within an interferon gamma-driven environment, and this might contribute to the tissue inflammation and destruction you see in there. Now, does norovirus add anything to this? And yes, in our eyes, norovirus adds to this. What we do see, we see single interferon response genes hyper activated within norovirus positive. And we here for this one, we used the non-villus atrophic patients and compared norovirus negative to norovirus positive. And you can see the hyperinduction of these genes in the norovirus positive tissue compared to, in blue, the norovirus negative compared to the change compared to healthy donors. When you compare, and this is in the last column here, the direct comparison of norovirus positive to norovirus negative, you see that the response to virus has come up, and this has been seen by Silje in the Norwegian patients as well. But you do also see the hyperinduction of gamma response and type 1 interferon responses, which you see here, while other pathways are decreased in the presence of norovirus when you do direct comparison. And again, you can see here more type 1, type 3. We can't distinguish between these two responses. Genes which are more activated in the norovirus positive compared to the norovirus negative, but also targets of the type 2 response like interferon gamma itself, as well as CXCL10. So yes, in our eyes, norovirus adds to the pathology, and the induction of inflammation is increased in the presence. Now, norovirus is not the only one. Here is a picture from an HIV review where you see very similar things happening in the HIV context with CD4 T cell loss, especially Th17 loss, abnormal enterocyte differentiation. I didn't go into that. But there you see in other disorders very similar things happening at the mucosal level. How can we help these patients, and why are they not able to control it? So IgA definitely plays a role. However, as mentioned beforehand, and I think, again, this is a very nice review, which you can see and read later on, but it is a combined effort of CD4, CD8s, and the IgA to eliminate. And if this is not successful, as in a chronic norovirus infection, this might add to the inflammation at the site through strong activation of the T cell compartment, which remains active in this site. Now, in summary, gastrointestinal involvement is common, and we need to look for it in CVID. This is definitely multifactorial, including genetic background, IgA deficiency, virus/norovirus, nutrition, microbiome, immunosuppression, and we will hear more about it. Gastrointestinal involvement typically presents as celiac-like disease in most of our patients, and it's predominantly interferon-driven, and T-cell-mediated dysregulation plays a major role within that. Norovirus is definitely not essential for the development of severe enteropathy in our patients, but if you have norovirus in many of our patients, it might contribute to the aggravation of this disease. The elimination has been shown that it clearly improves clinics and histology, and thus we need improved treatment strategies for norovirus, which is really frustrating at this time. I know David Lowe has worked hard on it and continues working on it. Therefore, as long as we can't really help this, we need to treat the immune dysregulation. And there are, including some of our patients, have clearly shown clinical improvement by addressing the immune dysregulation and ignoring norovirus, despite high secretion of norovirus under this treatment. And norovirus might not be the last virus involved in this. Others might contribute to this. And with this, I would like to summarize in brief: healthy gut, healthy you. I think this idea is right. And I also like to thank especially Valentina Strohmeyer, who has done the major work on this publication, which came out this year as well, and my group in the research. But it was not possible without pathology, the outpatient clinic, and the genetics, which helped us to define also certain genetic backgrounds within this. The microbiome analysis and the gastroenterology was essential. Peter Hasselblatt, bioinformatics. And with this, I would like to thank you for your attention.
Thank you, Klaus, for your interesting presentation. Well, the questions will be answered later. I see there are already a few questions in the Q&A section, but we will continue with our next speaker. And our next speaker is Helen Levis. She's a professor at UMC Utrecht. She specializes in primary immune deficiencies, especially in transition care, and long-term follow-up after stem cell transplantation for primary immunodeficiencies. She will tell us something more about microbial dysbiosis in CVID. So Helen, please.
Thank you, Boris, for this very kind introduction. So I hope you can all see my slides like this. I guess so. So these are my disclosures. So today I'll try to give some backgrounds on the role of microbiome in inflammatory complications in CVID. Of course, I'll start off with all the inflammatory complications that can occur and the most known evidence that these patients don't do as well as our patients with only infections. This is from the group of Helen Chappell, and of course,
sorry, Helen, I apologize, but we don't see the slides.
You don't see. Oh, sorry about that. Is this okay?
Yes, perfect. Thank you.
Okay. Sorry, 1 minute. Sorry about that. So again, this is on CVID with inflammatory complications, and that patients with these inflammatory complications do less well. We know it from the group from Helen Chappell, and of course also from a slightly more recent publication from Resnick et al. And we all know that it's not only defective B cells, and again, this very pretty picture from publication from Celia that represents all the different immunologic mechanisms that are apparent in these patients who develop inflammatory complications. And for a long time, it was speculated whether the disturbances of the gut microbiome, like in other diseases, might be one of the missing links to understand why some of our patients develop these complications. So we speculated on that a while ago. Since there is this strong association with IgA deficiency, we thought that might be one of the drivers, like several other groups, of course, also did, and that local dysregulated microbes in the gut may lead to continuous stimulation in this gut, which could subsequently lead to systemic inflammation as well. So we started off with measuring serum IgA and fecal IgA in our cohort, and we found a clear association with a very low IgA concentration in the stools as well as in serum in our patients with inflammatory complications. I apologize if I don't have the time to present all of the data that is present on the microbiome, but of course the first publication of microbiome in CVID was by Celia's group from Oslo, where they studied the microbiome in 44 patients with CVID, and about 80% of these patients had inflammatory complications, and they included controls and also IBD patients. And like in many other immune conditions, the complexity of the microbiome is reduced, which is shown here by a reduction in microbial diversity. And this is specifically the case for the patients with the inflammatory complications. In addition, they looked at associations with reduced low IgA, where this diversity was more pronouncedly reduced. And they looked at bacterial translocation, which is reflected by increased LPS in the serum of these patients. They did 16S sequencing, which is a way how to study the microbiome, and found several bacteria associated with CVID, of which Enterobacteriaceae and, for instance, gamma proteobacteriae. Then a few years later, there was the second publication from the Czech Republic by Fyodorova et al. And they studied patients and and controls, and some of them were paired controls. And they studied about 44 patients in total and also 44 controls. And what they showed by grading the severity of inflammatory complications by the classification by Amaratunga et al., they also found a reduced complexity of the microbiota in patients with more severe complications. And they found an association of Streptococcaceae and Lactobacilliaceae with CVID, but not so much with Enterobacteriaceae. Okay, so then there was this publication which was really interesting from the States, from Sulshul-Shenko et al. And they studied the gut microbiome in duodenal biopsies in a relatively small group of patients, so 7 CVD patients with enteropathy, 8 without, and 7 controls. But they were actually the only ones that studied the microbiome in this gut tissue. And because this was a very small subset, it was hard for them to find associations with specific bacterial species and this enteropathy. But what they could do when they worked around with a different method, they could associate a low IgA with presence of Acinator baumannii. And in addition, they co-cultured macrophages from these THP1 macrophages with Acinator baumannii, and they found that this also induced interferon production. So this is sort of an indirect link that several bacteria might be behind some of the problems we see in the gut, as Klaus already showed. Then from the Freiburg group, I think this was mostly an effort from Bodo, they also looked at the microbial composition, but they reasoned that maybe patients with diarrhea might have very different stool composition of the microbiome than patients without. And from a larger cohort, they selected 50 patients with diarrhea and 15 without, and several matched household controls. And what you can see here again is a reduction in the complexity of the microbiome by the Shannon diversity. But it was difficult with these numbers to find specific associations with several bacteria species, which of course is interesting to reason whether there are certain pro-inflammatory bacteria that cause these phenotypes. So then we get to the next publication, which I think is really interesting, from the group from Charlotte Cunningham-Randalls from New York. And they looked at a relatively large cohort of 90 plus patients and several controls with CVID. And they looked at the presence of a bacterial DNA measured by 16S sequencing again in the serum of patients. And this seemed to be increased in patients with inflammatory complications. And it was also associated with immune activation markers such as CD14, reflecting monocyte activation. And they also looked at markers that reflect impaired integrity of the gut, like zonulin and IFAB, which is also increased in CVID. And these patients, of course, had again increased interferon gamma in the blood, and especially in CVID. But this also was associated with higher bacterial counts in the blood. So they subsequently did co-cultures of PBMCs with bacteria from the patients. And interestingly, in patients with CVID and inflammatory complications, this resulted in increased production of interferon gamma. So another hint that gut leakage and bacterial migration to the systemic circulation may lead to inflammatory complications. And of course, I cannot forget the group from Guy Goroshov from Paris, because they did some very important work on mucosal immunology in relation to microbiome. So first of all, they had several publications where they looked at selective IgA deficiency and healthy controls. And what they showed is that in patients with selective IgA deficiency, it's probably not only IgG, but IgM in these patients that can target the gut microbiota, since they have higher fractions that bind to bacteria and stools compared to healthy donors. And that's where it goes wrong in patients with CVID. If you can see in panel B, you can see that IVIG from patients with CVID don't target the bacteria in the stools as good as normal IgG from healthy donors. And they compared this fraction of IgG-bound bacteria in the stools of patients with CVID with inflammation markers, here is CD14, and they see a correlation with an increase in inflammation associated with a reduction of this fraction of stool-bound bacteria. And again, systemic inflammatory markers were increased in these patients with CVID. So this is a hint that absence of IgA and IgA-M and not own production of IgG might be linked to inflammatory complications in CVID. So what then about our own work? We're hopefully publishing soon. This is also work that has been performed over the years. We biobanked a cohort of patients with and without inflammatory complications in CVID. And we looked at histopathology first of patients with CVID. And just as Klaus mentioned, some of the disturbances in patients with CVID is that the crypt length is much wider than normal. So what we saw with these immunofluorescence images is that the microbiota penetrated these crypts much deeper than in normal controls. And this is also an indication that there is bacterial translocation in these patients. So we measured bacterial load in stools in our patients, which were higher in patients with immune dysregulation. And we measured reduced alpha diversity. And then, since we had relatively larger numbers of patients with immune dysregulation and those without, we were able to look at associations not only of specific bacterial species or genera with CVID, but also with CVID and inflammatory complications. And what we saw was an enrichment of enterococci in these patients with non-infectious complications. And actually, after validation of the entire cohort, these seem to be different enterococci, but especially Enterococcus gallinarum and Enterococcus here were very pronounced present in these patients. So as another way to prove pro-inflammatory potential of these bacteria, we co-cultured dead bacteria with monocytes from patients and controls, and compared 4 different enterococcal strains that we cultured from these patients with E. coli, and they evoked higher IL-6 responses from these assays. And in addition, we did work on cytokine profiles in patients in our cohort with inflammatory complications. And by looking at patients with and without Enterococcus gallinarum, we found that several inflammatory markers such as IL-10, IL-7, and LILRB4 and FLT3L were increased in patients that were carrying this bacterium. So we found an enrichment of enterococci in our patients with CVID and inflammatory complications. And we know that presence of different enterococci is associated with IBD and SLE and also autoimmune hepatitis. Interestingly, also seems to be associated with an improved response in patients treated with checkpoint inhibitors in cancer. And some of the work that has been published on some of these bacteria is Enterococcus gallinarum in mice and men, where they prove that it translocates and drives autoimmunity. And what they showed in this image is that in gnotobiotic mice, colonization with this bacterium led to loss of expression of junctional proteins, which again is associated with impaired barrier function of the gut. Wrap up, microbial dysbiosis is prevalent in CVID with especially inflammatory complication, especially in patients with a low IgA. It's associated with systemic inflammation and a lot of different clinical symptoms of immune dysregulation. We know that there is an increase of bacterial DNA present in CVID, especially those with inflammatory complications, that these patients have impaired barrier function of their guts. Nevertheless, actually all of these studies are cross-sectional, and we suggest the role of enterococci, but a lot is needed to really prove that there is a causal relation with disturbed microbiome composition and inflammation. Ideally, we need to have longitudinal cohorts, have not only data on 16S sequencing, but also higher resolution. So then you have to go to real bacterial species level with metagenomics. We'd love to have some evidence from fecal microbial transplants, for instance, in animals. I know there is a publication that's up to be published. It's already published in preprint online. But yeah, we would love to see a relation with FMT and inflammatory complications. This is part of the work which still all needs to be done, and hopefully you enjoyed some of the evidence that's out there that shows that there's a role for microbiome in CVID inflammatory complications. So I need to acknowledge Roos, who did most of the work actually on our microbiome work. She defended already a while ago, and the rest of our group, which of course was all needed to do this kind of with this work.
Thank you, Helen, very much for your lovely presentation. It was very interesting to hear it. Well, we will move on, and our next presenter is Silje Jørgensen. She is a professor at Oslo University Hospital. She's a senior consultant at Section of Clinical Immunology and Infectious Diseases and a researcher at the Research Institute of Internal Medicine at Oslo University. She works with adult patients, and her main focus is the study of interplay between gastrointestinal inflammation, gut microbiota, and metabolites in CVID.
Thank you for that kind question. I'm going to present data on metabolic disturbances in CVID and the potential relationship to inflammation and gut microbiota. First, just some general definition. Metabolomics are defined as the comprehensive studies of metabolites, and metabolites is a low molecular weight biochemical substrate, intermediates or end products of enzymes mediated reaction present in a given biological system. So while genomic, transcriptomics and proteomics altogether provide information of what might occur within a biological system, metabolomics reveals what is currently occurring or has happened as a result of these other layers of biological regulation. So when we talk about metabolomics, we're not just talking about what's going on in the blood. Metabolism is also occurring in the gut or in the bloodstream. But when we talk about blood metabolomics, we're talking about the small molecule substance found in blood, which can be endogenous or exogenous. the majority of the compounds that enter the body through the oral route may potentially be metabolized by gut microbes, resulting in a large number of microbial byproducts entering the circulation of the host. And the activities of such metabolites may interfere with the immune system, actually also the CVID. There are quite a few specific classes of microbiota-derived metabolites that be studied in and implicated in other pathogenesis of metabolic and inflammatory disorders, but not many are studied in CVID. With a few exceptions, there is a recent publication on TMO, where we look at the TMA, which is the precursor of TMO, and also on lipids. So firstly, the gut microbiota-dependent metabolite, TMAO, is linked to many metabolic and inflammatory diseases, such as cardiovascular disease and type 2 diabetes. So these carnitine, betaine, and choline are mostly acquired through the diet, and diet containing TMO precursors are here symbolized by egg, meat, and shellfish. Then carnitine, choline, and betaine are metabolites by gut microbes to the TMO precursors, TMA. And this can either be by the bacterial enzymes, here CUT-C or CNTA, or it could be via the small intestine with the gamma BB intermediate back to TMA. And TMA is then passively absorbed from the gut to the portal circulation and delivered to the liver. And in the liver, it's oxidized from TMA by FMO3 to TMO, and then it enters the circulation. And TMO has shown to be associated with inflammation in many other diseases. So we hypothesized that this was also the case in CVID. Here we can see that in plasma of CVID patients, TMO is increased compared to controls. And this is also true for all the other metabolites in the carnitine TMO pathway, such as carnitine, betaine, choline, and also the gamma BB. But could this only be due to diet? We know that disease can affect how patients eat. We therefore looked at how much meat, fish, egg, and milk, which is our food rich in these metabolites, that CVID patient ate compared to the normal population. But we did not find that the CVID patient ate any more meat, fish, egg, or milk than the general population. So we concluded that the increased TMO that we found in CVID is probably not due to take of this kind of food. So our next question was, could this increased TMO be due to an altered gut microbiota? Helen mentioned the gamma proteobacteria, which is one group of taxa that's increased in CVID, and this was one of the important taxa in our first publication in 2015, which was increased. And in a later publication, we also found that at genus level, Escherichia shigella was increased in CVID. And the reason that we looked particularly on these bacteria is because they have been associated with the TMO previously. And indeed, we did find a significant correlation between the amount of gamma proteobacteria in feces and TMO in the blood. And this was also true for Escherichia shigella. Then we looked at these enzymes that I told you in the last slide that was important for the metabolism from carnitine, choline, and betaine to TMA. And we then compared the genes for these enzymes in pieces from CVID patient and healthy controls, and found that both of them were increased in CVID compared to healthy controls. So we could probably conclude that this could be a reason why TMO is increased in CVID and not diet alone. Then we looked at if it also in CVID is a correlation between this gut-derived metabolite and inflammation in the blood. And we did find increased correlation between EL12 and TMO, TNF and TMO. And we looked at LPS, which has also been mentioned in the previous talk. This is a gut leakage marker. This was also correlated with increased TMO. So this is what occurs in all patients, but this is what we think is going on in CVID. We think this is CVID-related dysbiosis with increased gamma proteobacteria, increased catalytic enzymes, increased LPS, and this contributes to the increased TMO in CVID. And again, this is associated with increased inflammation. Interestingly, we looked at some food groups within the CVID population to see if they were associated with increased TMO. We found that the patient that ate more table sugar, white sugar, had increased TMO, whereas the patient who drank red wine was protective of increased TMO. And this is could have a rational explanation, since red wine may contain compounds inhibiting of microbial TMA formation, such as DMB, which reduces the potential for hepatic TMA synthesis. So moving on to lipids, we have previously shown that in CVID, HDL, which is thought to be anti-inflammatory, is reduced in CVID compared to healthy controls. And it was a significant difference in the CVID patient with non-infectious complication compared to infection only in terms of HDL levels. We also looked at the association with the inflammation and measured soluble CD25, which is a marker of T cell activation. And here you can see the lower the HDL, the more soluble CD25 in the blood. This was also true for CRP. We then carried on to look at triglycerides, which is pro-inflammatory, and all particles of sizes of VLDL in CVID. VLDL is the main transporter of triglycerides, and there's a very strong correlation between triglycerides and VLDL in blood. And you can see here 0.985 is a very strong correlation. So most of what we found was true for triglycerides was also true for VLDL. And we found that CVID patients had increased triglyceride levels compared to controls, and this was also true for all sizes of VLDL. Then we looked at if the triglyceride levels was related to CRP, to inflammation also in CVID, and found that there was a correlation between triglyceride levels in the blood and CRP, EL12 and EL6 in CVID. And again, we also looked at the difference between the complication subgroup, which is the CVID patient with the autoimmune and inflammatory complication, compared to the one with infection only, and there was a significant difference in triglyceride levels. We then looked at the correlation between triglycerides and LPS, and here we found a very strong correlation with the correlation R of 0.615 with a very low p-value. And we found this very interesting because 90% of the plasma LPS are shown to be lipoprotein bound with the highest binding capacity to the HDL. But this is not the case in CVID. There was no significant correlation between HDL and LPS. So in CVID, it looks like there's a shift from binding to HDL to triglycerides. And we have seen a similar picture in other diseases like HIV and type 2 diabetes and sepsis. And then we looked if there was a correlation between triglyceride levels in blood and the microbial dysbiosis. Firstly, we looked at the alpha diversity, which is more the general number of bacteria in the gut, and we found no significant correlation. But if we looked at the dysbiosis index that consists of these 10 taxa here, that's specific to CVID, we found there was a significant correlation. So the more dysbiosis in the gut, the higher the triglyceride levels in this cohort. Of course, when you do the study on triglyceride, there are potentially confounding factors. Again, we looked at the diet between CVID patient and the controls and found that the total energy intake was the same. Also, it was the same intake of fat, protein, and carbohydrates. We also looked at if the patients in this cohort had increased cardiovascular disease. And this cohort consists of 95 CVID patients, and only 15 had cardiovascular disease, where 13 of them had hypertension that needed medical therapy. And there was only 2 with atherosclerotic disease. And when we compare this with the Hunt study, which is a big national study in Norway, there was no difference in cardiovascular risk in CVID compared to the general population. But of course, this is around 100 patients, so we have to have a larger cohorts to say with certainty that there's no increased cardiovascular risk in CVID. And then we looked at the age, because in the general population, triglyceride levels increases with age. But actually in the CVID patient, it was the under 50 group that actually had a significant difference between CVID and healthy controls, although the levels was higher in the above 50 patients. And finally, we have also published a paper on fatty acids in CVID. And this is a simplified illustration of the metabolism and biosynthesis of the N3 and N6 PUFAs, also known as omega-3 and omega-6. And the possible role of gut microbial modulation of dietary fatty acids. And here is the essential fatty acids in blue, and the other ones are in gray. And what I highlighted here is the most abundant omega-3, which is the EPA and DHA, which have these anti-inflammatory compounds that they produce. When we looked at the fatty acids, there was the N3 PUFAs as a group did not reach significant, it was just a trend that CVID was reduced. But when we looked at EPA and DHA, which is the most important anti-inflammatory fatty acids, they were significantly reduced in CVID. When we looked at N6 PUFAs or omega-6, they were significantly reduced as a group, but within this group, there are some pro-inflammatory and some anti-inflammatory. And LA is thought in recent publications to be anti-inflammatory, and this was reduced in CVID. And from all the cardiovascular publication, there is commonly made an anti-inflammatory index, which is the potential anti-inflammatory fatty acids here, relative to the potential inflammatory fatty acids, which is ARA, which is the N6 PUFA. And this was reduced in CVID, suggesting that CVID have an unfavorable fatty acid composition. And they also make a similar index for omega-3. But what was really interesting is that when we correlated the IgG levels, there was a significant positive correlation between N3 PUFAs or omega-3, DHA, which is one of the most common N3 PUFAs, and the omega-3 index. So the higher the IgG levels in these patients, the higher the fatty acids. And a recent animal study, I think it was in piglets, there was a need for appropriate absorption of dietary EPA and DHA, which is omega-3 from the gut, and that was dependent on the presence of plasma IgG. So this observation offers an interesting hypothesis regarding the link between favorable fatty acids, gut absorption, and the immunological features, which is also treatable in CVID. So moving on to the correlation to the gut microbial composition, there was no significant correlation. This is a different alpha diversity measurement, reflecting how abundant the gut microbiota are. And the higher values, the better, the more diverse microbiota composition you have. So there was no significant correlation with the N3 PUFAs, but there was a correlation with the N6 PUFA, particularly the LA. And when we looked at, this is the 10 taxa making up the CVID dysbiosis index published in 2016, and we also published an expanded cohort which included 5 more taxa at genus level, and we found that for omega-3, the M3 PFAS, there was a negative correlation with this bacteria, the Dyssulfovibronacea. So there's a correlation with a specific taxa in this data set. And again, we did not find, we could also narrow it down to PFAS in this diet questionnaire, and there was no significant intake of PFA or fat, protein, or carbohydrates between the CVID patients and the controls. So what we've seen so far, if you compare CVID with the metabolic syndrome, they have the ones written in black are similar in metabolic syndrome, with the blue ones are different. So CVID patients have reduced HDL, increased triglyceride levels and VLDL, and they have an unfavorable profile, fatty acid profile. But they have a normal LDL and a normal cholesterol. They have increased inflammation and reduced gut microbial diversity. However, on average, they have a normal BMI. We haven't found any evidence of an increased cardiovascular risk compared to patients with the metabolic syndrome. And both have different kind of liver involvement, NRHA of CVID patient and fatty liver of CVID, and both have increased TMAO. So we have hypothesized that in CVID patient with autoimmune and inflammatory complications, there is a pathogenic loop between persistent low-grade systemic inflammation, metabolic disturbances, and gut microbiota in CVID. I want to acknowledge my whole team that has been working on this publication, and particularly Magnhild McPherson and Tony Skarpingland, which has been the first authors of these publications and has done a lot of work to get these papers published. Thank you.
Thank you, Silja. Thank you very much for your interesting talk. And our last presenter for today is Georgia Melamed. She is a professor of gastroenterology and hepatology working in Paris, France. She's an expert in intestinal autoimmune and inflammatory diseases, as well as intestinal lymphoproliferative diseases and enteropathy associated with primary immunodeficiencies.
Thank you for the organizers for your invitation to present the differences and similarities between celiac disease, autoimmune, and CVID-related enteropathy. So celiac disease is a gluten-induced enteropathy characterized by intestinal villus atrophy induced by gluten. And villus recovery can be observed after 1 to 2 years of gluten-free diet. Celiac disease occurs in genetically predisposed people having the susceptibility haplotype HLA-DQ2 and or DQ8. So the diagnosis is suspected with positivity of anti-transglutaminase IgA, and is confirmed by duodenal biopsies showing villus atrophy, increase of intraepithelial lymphocytes, and possibly in children, we can not perform biopsy if serum anti-transglutaminase IgA is superior to 10 normal value and in presence of anti-endometrial antibody. And the diagnosis is confirmed also by the clinical and histological improvement under gluten-free diet. So this slide presents the macroscopic aspect of villus atrophy, scalloping aspect with a mosaic pattern, and the histology, the villus atrophy, which correspond to Marsh 3 classification. And in all cases, you can observe an increase of intraepithelial lymphocytes. And also in Marsh 2 and Marsh 3 stages, cryptic hyperplasia. And lymphocytic gastritis is observed in 30% of patients and lymphocytic colitis in 12% of patients. So the clinical spectrum, in fact, of celiac disease in adult involve mainly POSI or asymptomatic forms, and the classical presentation associated diarrhea, malabsorption, abdominal pain is only observed in 10 to 20% of patients at adulthood. And main cases present with isolated anemia or liver cytolysis, osteopenia, neurological disease, other autoimmune disease, reproductive disorders. So 15% of celiac patients developed another autoimmune disease, particularly type 1 diabetes and autoimmune thyroiditis. Concerning the strong association with herpetiformis dermatitis, if you perform duodenal biopsies in these patients, you can find celiac disease in 90% of them. And gluten-free diet has a protective effect against onset of autoimmune associated disease. So a small group of CD patients are refractory to gluten-free diet. And there are two types of refractory celiac disease, the type 1, which is a benign type with increase of intraepithelial lymphocytes with normal phenotype, and the type 2, which is the lymphomatous type, characterized by increase of IL with abnormal phenotype and clonal repertoire. And this form has a very more severe presentation with ulcerative jejunitis in 70% of patients and a high risk of developing overt lymphoma, enteropathy-associated T-cell lymphoma. So concerning the benign type, RCD1, in fact, the diagnosis is difficult because there are no clear difference with active celiac disease, excluding the resistance to gluten-free diet. Patients have more frequently 2 copies of susceptibility HLA-DQ2 haplotype, and there is an excess of microscopic colitis. Treatment relies on budesonide and immunomodulators, but we have to eliminate other cause of enteropathy with villous atrophy, such as the enteropathy associated with common variable immunodeficiency. And in patients with CVID and gastrointestinal manifestation, you can find duodenal villous atrophy in half of them with frequent intraepithelial hyperlymphocytosis. And these patients are commonly refractory to gluten-free diet. So there are some histopathological signs particularly associated with CVID, such as the lamina propria plasmacytic rarefaction, and such as the frequent follicular lymphoid nodular hyperplasia in the lamina propria. The patients have variably the susceptibility HLA-DQ2 haplotype to 20 to 77% of them, and very rarely anti-gliadin antibody. But they are frequently in peripheral blood circulating T-CD8 hyperlymphocytosis, autoimmune, extraintestinal autoimmune disease, but different from celiac disease concerning autoimmune thrombocytemic purpura, hemolytic, autoimmune hemolytic anemia, Sjögren's syndrome. There are frequently autoimmune atrophic gastritis and microscopic colitis in 27% of patients, and treatment also relies on budesonide and immunomodulators. We also have to eliminate another type of enteropathy with villous atrophy, which is autoimmune enteropathy, which first was described in a pediatric population with the IPEX syndrome, occurring in very first days of life with severe diarrhea, malnutrition, type 1 diabetes, thyroiditis, hemolytic anemia, linked to mutation of FOXP3 genes, which impairs the normal function of CD4 and CD25 regulator T cells, associated with a lot of autoimmune disease, and treatment relies on immunosuppressive drugs and autologous stem cell transplantation. And then several short series of adult autoimmune enteropathy were described, notably concerning patients with diarrhea resisting to any alimentary exclusion, frequent extraintestinal autoimmune disease, positivity of anti-enterocyte antibody, but also frequent association with serum positivity, positive antitransglutaminase antibody. One particular histopathological patterns frequently associated to villous atrophy in autoimmune enteropathy are these glandular apoptotic lesion and autoimmune enteropathy. Patients with autoimmune enteropathy have also frequently lymphocytic colitis, gastritis, and atrophic gastritis. Possibly genetic factors favors autoimmune enteropathy. Indeed, we have performed the genetic analysis of a series of 48 adult patients with autoimmune enteropathy, and we found that 42% of them had a susceptibility pathogenic constitutive gene variant, notably of CTLA4 haploinsufficiency, but also STAT1 and STAT3 gain of function. Patients with autoimmune enteropathy with or without a common variable immunodeficiency. And the expression of the mutation was very variable also within a same family, as for example, in one studied family with STAT3 gain of function mutation, the sister had a severe enteropathy but no primary immunoglobulin deficiency, and the brother with the same mutation has severe enteropathy, but also primary immunoglobulin deficiency. So evidence of this pathogenic gene variant is very useful for the diagnosis. Indeed, in our experience, we had 2 patients considering as having refractory celiac disease because they were HLA-DQ2, they have the HLA-DQ2 haplotype, and because they had, before gluten-free diet, serum IgA antitransglutaminase antibody, but in fact, they had autoimmune enteropathy, one associated with JAK1 gain-of-function mutation and the other one associated with CTLA4 haploinsufficiency. So there is probably a continuum between the genetics of this autoimmune enteropathy frequently associated with Mendelian disease with pathogenic variant concerning CTLA4, PTPN2, SOX1, and other genes involved in autoimmunity, and polymorphism found in the same gene in celiac patients, which is a polygenic disease. So evidence of pathogenic variant is very useful for the treatment, as we can, for example, use abatacept, which is an agonist, CTLA4 agonist in patients with CTLA4 loss of function and in patients with LRBA loss of function, but also ruxolitinib, which is a JAK1, JAK2 inhibitor in patients with STAT1 and STAT3 gain of function mutation. Notably, we described 4 years ago the case of a young woman of 26 years, ill since the very early childhood because of severe enteropathy with duodenal villous atrophy and lymphocytic colitis associated with an immunoglobulin IgG subclasses deficiency, and refractory to several lines of immunomodulators of biotherapies, and which had a very good clinical and histological remission with ruxolitinib after evidence of STAT3 gain of function mutation, which induced a huge decrease of CD3 lymphocytic infiltration of his intestine, of her intestine. So evidence of pathogenic variant, in fact, is predictive of a more aggressive disease course of this autoimmune enteropathy with an earlier onset enteropathy and an earlier onset of gastrointestinal malignancies, particularly gastric cancer and intestinal lymphoma. And if we want to make the summary of similarities and differences of these features. Celiac patients have all the susceptibility DQ2 and or DQ8 haplotype, variably found in CVID enteropathy and found in some series up to 56% of autoimmune enteropathy. Patients have celiac patients have celiac antibodies, anti-transglutaminase, but also anti-endomysial antibody, very rarely found in CVID enteropathy, but found frequently in 20 to 30% of cases in autoimmune enteropathy. The anti-enterocyte antibody is quite specific of autoimmune enteropathy, having or not this specific anti-enterocyte antibody according associated or not primary hypogammaglobulinemia, not found in the CVID enteropathy and very rarely found in celiac disease, and particularly, in fact, in case of refractory celiac disease, which is doubtful. Associated with villous atrophy, some histopathological features such as follicular lymphoid hyperplasia is found in CVID enteropathy, but never in celiac disease. And glandular apoptotic lesions are frequently observed in autoimmune enteropathy. Plasmacytic rarefaction indicates CVID enteropathy. The three types of enteropathy have frequently atrophic lymphocytic associated gastritis and lymphocytic colitis, and pathogenic gene variant is found in the autoimmune enteropathy in 40% of cases. Clinical and histological response is really a diagnostic criteria of celiac disease, because the two other types of enteropathy are not responsive. So in conclusion, when patients have villous atrophy refractory to gluten-free diet, we have to check the HLA-DQ2, DQ8 haplotype. We have to check if the patients had initial positive serum anti-transglutaminase antibody. We have to perform the ponderal dosage of immunoglobulin and the dosage of anti-enterocyte antibody. And there are some histopathology. You have to review the pathology specimen with your pathologist, because they may be very indicative of primary hypogammaglobulinemia, and to differentiate primary hypogammaglobulinemia from secondary hypogammaglobulinemia induced by protein loss enteropathy. We have also, I think, to perform more frequently genetic analyses, for example, using a specific targeted next generation sequencing enteropathy panel in patients with unclassified enteropathy to gluten-free diet, because of high frequency of susceptibility, pathogenic, constitutive genes variant in autoimmune enteropathy associated or not with primary hypogammaglobulinemia. And I would like to thank all my clinical partners of Cochin Hospital in Paris, from Paris Cité University, and the Laboratory of Intestinal Immunity at Imaging Institute. Thank you for your attention.
Thank you, Georgia. Thank you very much. It was nice to hear a gastroenterologist's point of view on all of this. We're basically running out of time, but I suggest that we answer a few questions. Maybe there are some questions in the Q&A, and maybe I would actually like to start with Klaus and to ask him about some future perspectives of treatment. There has been mention about some specific inhibitors of these pathways, for example, JAK inhibitors and also norovirus treatments. So what are your thoughts about that?
Yeah, thank you very much. Thank you very much to all of you. I think that currently not having a really good treatment for norovirus in the presence of norovirus, and there is evidence and I think Helen, I think you're maybe a person who can comment on it as well. I think with the increased interferon signature, and I think JAK inhibitors are definitely much, much higher on the role. And I think with the increased also allowed use of JAK inhibitors in this context, I think we need to consider JAK inhibitors in this context. Obviously, JAK inhibitors in the context of an ongoing viral infection is always a question. But as mentioned, I think it will be a potential helpful treatment option in patients with immune dysregulation, gut involvement in CVID, with and without, and this was one of the questions, with and without norovirus infection, but even with norovirus infection, I think we will have to be definitely trying to put that into a clinical trial so that we really have the maximum effect of learning from this. And so I think this is something which I think the field needs to look at, how we can accomplish this. So yes, that is. In regard to when can we expect good treatment for norovirus, I have no clue. I think at the moment there are many different attempts. Favipiravir has been suggested. There are 2 patients in London I know of which have been treated with very high dose of favipiravir. It is extremely difficult to get the drug. It is a pain. I think it's like 16 tablets a day. If you go for the standard regular daily dose, and they have increased it even beyond that to keep that norovirus negative. So I think here we need better forms, and whether it's a combination therapy, as it is often with viral infections. I think interferon lambda plays a major role with the control of norovirus. There is science, and I think that would be a question for me for Silje in regard to rifaximin, because it has been shown that probably bacteria, the microbiome plays a role, how well the norovirus survives. So I think there are different options, and I think we have to explore them, and I think we have to start doing it. I think, but when we are there, I have no clue. I don't know whether, Helen, you want to comment briefly on your experience with the JAK inhibitor briefly, and I think Silje, if you want to comment briefly on rifaximin as well.
Yeah, I could. So we measured interferon signatures in several patients, and one of the patients that was really, really ill that we published was a patient with enteropathy who needed TPN and who was in ICU all the time due to complete barrier breach in his gut and continuous bacterial translocation, and he already had very severe liver disease as well, and we couldn't do anything for him. He was on methylprednisolone all the time. And he was having norovirus. So we decided to give him a JAK inhibitor, otherwise he would die anyhow. And he completely got better. So we could stop his TPN, taper his steroids to 0. And now he's functioning well again. And I'm still concerned that he'll have loss of response, but this far he's really doing well. And it was not the norovirus that was killing him. But this is an NS1, of course.
Yeah, I can comment on the rifaximin. In our previous study, we didn't actually look at virus, just bacteria, so I don't know if they have any effect on the virus at all. But our cohort that we studied didn't have any patients that had norovirus. We had a few afterwards, after collected the patients. What we have run into problems is that when we've tried it on ribavirin, which firstly, it doesn't work, and secondly, the liver function gets a problem because they often have enteropathy and reduced liver function. So it's also a bit risky to give treatment that is not that we don't even know if it's working, and it can get more complication and drive them into complete liver failure, which almost happened to one of our patients. So yeah, so you need to be a bit careful as well when considering antiviral therapy, but also with anti-inflammatory is very experimental. So it's very nice that if we have positive experience from case report that people publish them, so we can all learn from our experience, because it's very difficult to get good large randomized controlled trials in CVID with rare disease and then a rare complication as well. So yeah, publish the case reports.
Thank you. I would like to ask Georgia and Helen maybe if they can comment. There have been some questions about fecal transplantation and probiotics. So when we speak about microbiome, I think that's also an important issue to tackle. So if the two of you can maybe just comment a bit on that, please.
Concerning the microbiome transplantation, yes, there is a dysbiosis associated with CVID enteropathy. But I think that it's probably not the main triggering factor. So I don't think that it would be useful to perform a microbiome transplantation in this patient. I think that it won't be. It is I see it as a consequence, but not as the originate factor.
And Georgia, if I may ask, in immune checkpoint inhibitor complications, there have been patients benefiting from FMT. How do you see that?
Yes, but I don't know exactly what would be the effect of such transplantation. So I don't have any experience, but as in IBD, it is debated because you have some positive clinical trial and some negative clinical trial in patients, immunocompetent patients with IBD, inflammatory bowel disease. I think that I won't use it in the first intention for immunocompromised patient because I have no enough scientific data to propose this type of treatment in immunocompromised patient because that doesn't, it's not so efficient, it's not very efficient. We have no in France clinical application in immunocompetent IBD in patients with inflammatory patients. So, and the other question is that a lot of patients with CVID have not IBD but have lymphocytic colitis, and they have a much more upper gastrointestinal lesion concerning the upper small bowel. And we know that, in fact, the microbiome is not so, has no the same impact in the duodenum part, jejunum part, that in the colon. So, and lymphocytic colitis, it's not, it's different from IBD. I think that the process is different. It's come probably from and there is a circulating hyperlymphocytosis, but not IBD lesions are very rare in CVID patient. They are not in first line of manifestation, histopathological manifestation. Lymphocytic colitis is much more frequent than IBD lesion.
If I may comment, I think it would be interesting to know more about the role of changing the microbiome and maybe local, but definitely also systemic inflammation. And I think that there is a significant role of IgA deficiency in the context of CVID that's very different to many of the other diseases that have been studied. But I totally agree to Professor Malamud that it will be difficult to perform FMT in patients that are severely immunocompromised, especially since in our country we have experience with problems of bacterial translocation in patients with severe pancreatitis that received duodenal installation of probiotics. So since you never can be sure that in stools from donors there are potential nosocomial pathogens that might drive inflammation, that would be difficult, but maybe in patients that are not severely immunocompromised and have initial signs of immune dysregulation, it might be it might be doable, and it might be not that dangerous in the end, but we just don't know. And it would be nice to have more, I guess, animal models that prove that by changing the microbiome you can reduce inflammation, and thus far this evidence is not there, unfortunately. And again, animals are not humans, so you also need to transform, use a human model to prove this if you really want to study this. And it could be true that inflammation CVID is different than other inflammatory diseases.
Okay, thank you very much. Well, we've actually ran out of time. There are a few more unanswered questions, but I see that Eleanor already wrote that the unanswered questions will be passed to the panelists. So you will get your answers later on. Well, we've heard that there are a lot of potential culprits in these CVID enteropathy and everything. It was wonderful to hear all these interesting talks, and I would just like to thank again to all the speakers and panelists for their wonderful talks. So thank you very much. Well, this actually concludes the 2023 Grand Round sessions, and they will continue, of course, in January 2024. Sorry, 24. So I guess that's it for now. Klaus, would you like to say something as well? Do you have something to add?
Very much so. Boris, you're excellent. First of all, thank you so much.
you.
You did a fantastic job on doing this. And yes, I would also like to thank ESID for the opportunity and to do this, Eleanor for organizing, Siobhan for having created the webinars like this, which I think is a fantastic way of exchanging information. And as it was said, I think we all need to learn from these cases. And so please, publish them. And so hopefully one day we have a better cure for enteropathy, which I think is a huge problem in our patients. And so thank you also from my side very much. I wish everyone a good closure to the year. Merry Christmas, whoever celebrates this, and hope to see you next year. Thank you. And thank you to the speakers, obviously, which really was brilliant. Thank you so much for that.
Thank you very much. Bye.